folks, I'm here at the airport in Vegas heading out to New Orleans for the AAE meeting. I showed you the NAB meeting, and now let's go take a look at the AAE meeting in New Orleans. Finally got here to New Orleans. It was a much harder trip than I thought. It's like 11 p.m. so I gotta get my luggage and head out to the hotel. Look, it's so late, there's nobody here. Before I go upstairs, I gotta find out what is this noise coming from outside. Well, we're on Bourbon Street. Oh, it's a Tuesday we're crying out loud. It's too late for me, I gotta wake up early in the morning. The only thing we need at this hotel is a few beads, you know. Oh my God, look at this. I found out that this guy here, earplugs. Ah! Okay, picked up the badge and the coffee. And let's get into the exhibit hall. What's up, guys? This is our Harvard residents and dental students here. What have you seen? Have you seen anything cool? We just started, okay. So I'm here with Dr. Safi. You guys all remember him? So what did you see so far?
So far, first half, he assisted to Dr. Kim's live surgeries.
That was pretty impressive, wasn't it?
That was very impressive. He did
so live presentation using 3D.
3D presentation via Zeiss microscope. It was very good.
You're Endo resident and also a recent graduate who's opening up a practice in DC.
Yeah, it's been great so far. We just actually came out of Dr. Kim's lecture.
There's a lot of stuff to learn. I guess as long as you have the spirit of learning, you'll do fine. Okay folks, it's presentation time, heading out to the convention. All right, boss. Thank you so much, man. Appreciate it. Have a good one. Okay, take care. Bye-bye. About 20 minutes before my presentation, I've had to quickly run back to the hotel because I forgot this connector. Oh, it's always something with these stupid connections for the presentations. About 5 minutes before my presentation, and I'm just coming back. Okay, look who I ran into, Dr. Song Woo here, one of our residents, graduating this year.
It's been great. I learned about the insurance payment system in the morning.
Very important as a graduating student to know how you're going to get paid at the end. One and only Dr. John Stropko here. John, what have you seen so far in the meeting?
I've seen some really great speakers, you being one of them.
Oh, thank you. You're giving a talk tomorrow yourself.
Yes, I am. Alternative treatments for external cervical resorption.
Oh, God, how many of those do we see
Yeah,
nowadays?
quite a few now.
Chronically. What do you think that is the cause of it? What do you think it is? Do you think more ortho is being done now?
Ortho and trauma. And you can add, I think, malocclusion into that trauma situation.
I'm here with the inspirational speaker and wonderful endodontist in Atlanta, Georgia.
A lot of cutting-edge technology here. Some of the CBCT lectures have been really interesting. Some guy says, you know, watch your scan.
That seems to be a big controversy nowadays. How much information is enough information, right? Considering the cost.
You have this expensive machine, you know, who do you scan and why? You know and I know sometimes it can take 8 years, up to 8 years for a lesion to heal. Do you keep scanning them or you say enough is enough?
We've gone through this in medical care as well. More information is always better, but at some point you end up over-treating and causing excessive costs, which is what's been increasing the cost of care. That's the technology, and we're going to have to find that right balance. I'm sure once we put all our minds together, I'm sure we're going to come up with some kind of a consensus.
Absolutely, absolutely.
Everybody knows Jerry. We've done some videos here together. He's a big watcher of our videos.
So they're very useful in order for that educational process to be a much easier, less
stressful way of preparing for the examination. You'll be on the video now.
Enjoying the show, enjoying seeing good friends with you.
So, what have you seen here that has impressed you?
We saw the new file from Browser. It's called XP3D.
Okay.
It looks awesome.
That's not a product placement. That's actually, I didn't ask him to say that, but go ahead. What else?
It's impressed. Zeiss has a new microscope.
I heard Zeiss's scope is pretty interesting. What is it? So tell us what's special about the Zeiss scope.
They have a new light, so you can identify like caries. It's a green light.
First year endo resident at Nova Southeast University, and Ron, you got an interesting case that you shared with me here, and you had it on your iPhone, right? So there's some internal resorption in this case, and why don't you give us a little bit of history here about this?
Tooth number 24, that it was internal resorption, so we decided to put out treatment. The XP shaper and the finisher as our primary instrumentation after we achieved the glide path. Decided to use the BC sealer as our obturation, which is where the resorptive defect is exactly. And we notched it, and that gave us access to the defect. After notching it, we used the remainder portion of the gutta percha cone and used more BC sealer and attempted to pump it into the defect. And once we got the best result we could, we seared off the coronal portion of the cone, and that was it.
Okay, so it's Thursday afternoon and the presentation is over. Finally heading down. Thursdays is where the alumni dinners are for the schools. So I'm gonna head out to the Harvard alumni dinner and going over there with my date. I figured I'll take you guys to the Harvard alumni dinner as well so you can see what is going on over there at these alumni association dinners. Let's go.
Harvard School of Dental Medicine, and going on really very close to 50 years of Harvard endodontics. And as I look around, what really counts are all these children that I see here. I see here, we couldn't be more proud with you.
I just want to talk briefly about the menu, if it may be the first time for anyone, to Antoine's. Now, Antoine's is the oldest restaurant in the country, 177 years. Right? This is world famous. This was started here in 1889. There's no spinach in our Rockefeller, opposed to most restaurants you go around the world. Since 1840. Ice cream, pound cake, and
About 25,000 bottles of wine. Right now we're around 20,000.
How many feet is it?
175. You see that? It's not a mirror down there. It's actually a window.
So, I mean, what's above it though? The restaurant is...
The restaurant, yeah.
The restaurant entrance.
The poster clinics were and the table clinics were at the same time as my presentation yesterday, so I kind of missed it, but I'm just kind of walking around taking a look at a couple of different posters and so I can share them with you. One of the ones that I saw that I wanted to share with you is this particular one in Kentucky, and what they did is they did a little survey to find out the prescription habits of general dentists and endodontists for antibiotics and pain medication, where patients have symptomatic irreversible pulpitis, which means that the inflammation is confined to the pulp and not so much at the apical area, and the patient's having pain. Unfortunately, a very large number, 61% of general dentists prescribed antibiotics for these patients. 10% of endodontists prescribed antibiotics as well for these types of patients. And that is not something that's it's a poor indication for the use of antibiotics. Antibiotics will not do anything to resolve the problem of irreversible pulpitis inside the pulp. And in fact, it could be more harmful, not only because of all the GI issues that I've mentioned in other videos that it could cause and killing the biome itself,
but also primarily because of the fact that it could prolong the pulpal death. So the patient actually stays in pain for longer when you're prescribing antibiotics in patients that have irritable pulpitis. So make sure that if you have a patient that has irritable pulpitis, you're not prescribing antibiotics to them. The best treatment for them is actual root canal therapy, to go in there and do a pulpotomy or somehow get rid of the inflamed pulp. The only reason to give an antibiotic to a patient is if they have systemic signs of infection, such as fever and things like that. University here. This is an interesting case of the use of CBCT. I was discussing a little bit earlier on the floor where CTs should be used, and here they did a pretty interesting study where they kind of looked at 104 cases that were treatment planned using the two-dimensional data of clinical experience as well as radiographs, two-dimensional radiographs and everything, and then they were sent out for CBCT. And then what they did is they tried to evaluate and see how the treatment plan changed based on the CBCT results. And what they found was very interesting is that about half of the cases, about half, 40 to 50% of the cases, the treatment plan changed after the CBCT was done. And one of the things that they also evaluated was the difference in the treatment plan based on the level of experience between the operators and the people that were evaluating the CBCT. They found that people with a lot more experience were kind of sometimes opting for the extraction, whereas people with less experience were opting for retreatment and doing some heroics. And that's pretty much what I have found myself clinically as well in my patients when I'm taking the CBCT. But again, this goes to show that CBCT maybe should not be a panacea for every single patient, but for cases in which you have a treatment plan and that you have a question which you want to confirm, it seems like from this study that about 50% of the times people change their mind. So CBCTs, thumbs up. Hey, when do you think we're going to finally have guided access preparations with using guides? Let me know in the comments. Little survey from Nova University, and what they've done is they surveyed a bunch of endodontists, general dentists, and board-certified endodontists to see what kind of access preparation do they prefer. The micro-access preparations, the conservative, or the straight-line access preparation. I actually remember getting the survey and I responded. And for me, I pretty much like the straight-line access most of the time, maybe a little bit conservative in some ways. But it just goes to show here, based on these statistics, that the micro-access preparations that you see online being touted as is not really preferred, but a very minority of people, especially in molars. These are the kinds of moves where you're trying to complicate endodontic therapy. I'm not for it. I want to simplify endodontics so that it could achieve more predictable results for most people and most of the patients, increase the success rates, rather than to make a procedure that could otherwise be simpler more difficult. At least I can get away from all these buzzing lights here at the convention center. It's been driving me crazy. With Fred from Dental Tribune. Fred?
Hey there. Oh, Tribune.
And the Tribune
and
here,
look
which
who's
is a
on the
publication.
cover.
Look who's on the cover. Wow, what surprise here. I guess that's my little presentation there, huh? So here we have the foundation. Saving teeth is what we do exactly. And inside is the news about the meeting. So how's your meeting been, Fred?
It's been a lot of fun.
Well, look who I ran into. Our own faculty director, Richie Herman here. Richie, how you doing?
I'm doing great.
Enjoying the meeting?
Yeah, really good.
So Richie, you showed me a couple of cases I want to talk to you about. First one is a premolar that you did with ESX.
Right.
Under a bridge, really tough.
Right.
3 roots ends up being, and you do a wonderful job filling it, all 3 canals, found them. Tell me a little bit how you went through this process.
We gained access, and in this case really shows you the importance of using the surgical operating microscope. I don't think I would have found the 3 canals without that microscope. And then we went ahead with our instrumentation protocol. I used the ESX, single stroke and clean. I started with a 1502 hand file, went to a 1505 expediter, and then I went to a 2504. I wasn't happy with the 2504. I went to 3004 and then recapitulated and went back down. And then I went to my irrigation protocol, which is very, very important. From there, I used U-files with hydrodynamic irrigation. And then I went ahead and used my bioceramic sealer. And it just shows you how the bioceramic sealer flows and the case came out absolutely, what I think, real nice.
It was wonderful. I think they did a great job with that case. And also what I found is that finding the third canal on these premolars that have 3 roots is very difficult. Of course, diagnosing it would be helpful having a CBCT.
Oh yeah.
Right?
Well, at that time I did not have a CBCT, but this is a case right from the get-go. I would use a CBCT. I would know there were 3 canals. It would make it a lot easier to find the canals. In this case, I used a pipette with some methylene blue, and I located the third canal. I think that helped a lot.
Yeah.
And then we went from there. But no question that CBCT is becoming as important as a surgical operating microscope, in diagnosis especially.
Absolutely. One little tip for these is that in premolars, where you find that normally your orifices would be aligned in a buccolingual direction, when you see that one orifice is a little bit off to the side, either mesially or distally,
that was the kicker.
That's when you suspect the third canal, right?
Yeah.
And of course, the preoperative graph would look weird. But you did a wonderful job with the hydraulic condensation, filling all 3 canals with size 30 cones. You have another case also, which is a molar. That's really a spectacular, amazing case. I love the distal root and this molar and the way you handled it.
Yeah.
And this one you use the endosequence file, right?
Yeah. Well, you know, the protocol with the instrumentation that we have, the endosequence went into the ESX, which is fabulous. But at this time I started on the distal canal. I started with 50. I always go to a 1502, do my glide path. Then I went to the, I go right to a 4004 in this case, 35, 30, 25. And then I recapitulated, but I couldn't get down. I got down to what the working length is, but I suspected there was something else there. So I did my irrigation with my irrigation protocol, which was great. And then the bioceramics using hydraulic condensation, look what we get. And that just goes to show you the importance of what we are doing now and how advanced it is.
Yeah, absolutely right, because this here shows that you can get enough hydraulics from hydraulic condensation to get the kind of puff and the branching that's happening at the distal roots with this simple technique.
Yeah.
So it's really wonderful.
So it's 2 things here. You got to really understand the irrigation, and you got to understand how well the bioceramics flows. It's fabulous.
Of course, having expert hands like yourself certainly helps as well. I'm sure it wasn't just the file.
Thank you so
right?
much, Ali.
It's like the Michael Jordan story. Like it's the shoes, right?
Yeah,
it's the shoes.
Shoes. You sure it's not the shoes?
I'm sure, Mars.
What about the shoes?
No, Mars.
Money's gotta be the shoes.
You're the best.
It's Richie's extreme experience and deft hands. So, Richie, where are you off to right now?
I'm off to another lecture, but thanks a lot, Ali. I really appreciate it.
Great to see you. Take care. Great guy. Okay, look who I'm here with. Here is actually Ann Koch.
Hello, hi.
So Annie, they're rolling the carpet. The meeting is over.
For sure. I thought this meeting was really terrific. I was speaking to a publisher from the UK, and they were doing an article for a magazine about kind of the 10 biggest things here at the AAE. Top 3 that come to my mind is the whole XP, endo, the shaper, and the finisher, expandable nickel titanium metallurgy. That's a big deal. I think the bioceramics is really becoming a gold standard of obturation. And of course, endodontists are the toughest group to have change over, but I saw a lot of that, not just with the sealer, but especially also with the fast set paste.
Yeah, that's true. I mean, there's been a lot of interesting and exciting changes in the in technology and the profession that's going on. The exhibits and the courses and everything was really wonderful.
Let me ask you a question. Did you say anything on implants?
No, that's totally gone.
And you know, one of the things here that I'm just going to let everybody know is that there's such a swing now with high-end prosthodontists going back to dentition-based fixed prostheses, like save the tooth. Okay.
That's right. I mean, that's our kind of motto, right?
Right.
Let's save some teeth.
Exactly.
Yeah, I think that's the future is looking really good for endodontics, and I'm really happy to be a part of this profession.
Absolutely.
There's a lot of people working together to develop techniques and technology.
And you know, one of the other things too is whether somebody uses the Dentsply instrument, somebody uses a Kerr, a Brass, or whatever. As healthcare providers and endodontists, 90% of the things we agree on.
Absolutely.
So don't make it personal.
No, absolutely. Yeah. I mean, it is about the. I keep on saying that it's about the foundations. It's about the fundamentals. You know, all of these things are just tools in our hands, trying to do the job that is really based on the science and the foundations.
Right.
So with that, let's save some teeth.
Too easy.
Hey you! Don't watch that. Watch this. This is the heavy monster sound. The nuttiest sound around. So if you're coming off the street and you're beginning to feel the heat, well listen, Buster, you better start to move your feet to the rockinest, rock steady beat of madness.